I do think things are changing a little bit. I do think that the waif model or the heroin chic model of the 80s is maybe not as popular as it was, but it's still out there, and girls are still wanting the flat stomachs, and it still is something that people talk about. Look, we're talking about it too. We're like, how much fat is too much? But the fact that we're talking about it, that's a plus. That's moving forward. The fact that we are not hiding it in the closet.
This is Fat Science, a podcast dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better. This podcast is for informational purposes only and is not intended to replace professional medical advice.
I'm Dr. Emily Cooper. I've been treating patients with metabolic issues for over 25 years. I'm on a mission to raise awareness about metabolic dysfunction and why diets don't work.
Hi, I'm Andrea Taylor. I've been fat, very fat, chubby, morbidly obese, and done almost every diet ever invented. They all worked until they didn't. I've known Dr. Cooper forever, but when I became her patient and we learned metabolism was the real problem, wow, everything changed, and I've never been healthier.
And I'm Mark Wright. It's time for Fat Science.
Wait, does this podcast make me look fat?
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. It's good to see you two. Welcome.
Hi.
All right, on the show this week, this is going to be a good topic. How much fat is too much fat? This is a question I think every human being, well, in the modern era, has struggled with, wrestled with, thought about. And Andrea, you worked your entire career in marketing, so you know how messed up the media messages are in our culture. So this is a tricky question. Andrea, do you want to launch us into the conversation? How much fat is too much?
Well, I would say that as a kid, I would just say any fat is too much fat. And now I would say, I don't know. I mean, we hear 0% body fat, 6-pack abs, 5% fat, 4% fat. I just, I look at pictures, I see them all the time of all these women and all these men, and I'm like, retouch. And then I look at other ads and I'll be like, oh, there's the token chubby girl, or there's the, oh, it's nice that she's using bigger dancers or whatever in their videos. And I do applaud a lot of singers and a lot of advertisers for using people who aren't stick thin and look like they're starving. And I do think things are changing a little bit. I do think that the waif model or the heroin chic model of the 80s is maybe not as popular as it was, but it's still out there, and girls are still wanting the flat stomachs, and it still is something that people talk about. Look, we're talking about it too. We're like, how much fat is too much? But the fact that we're talking about it, that's a plus. That's moving forward. The fact that we are not hiding it in the closet. I mean, when I was a kid, nobody talked about it. It was something that everybody was embarrassed about. Everybody was wearing a girdle to not ever look like they had any bumps, lumps, or anything. And I mean, we still are wearing those Spanx. We just call them something else. We call them Spanx. We call them body shapers. But it's at least talked about, and people talk about curvy girls, and people, it's out there. But as a kid, and I think even now, even as kids grow up, believe me, nobody wants to be, I mean, there is a fat positive movement that people talk about, but there has to be a movement for it. And the fact that there has to be a movement for it means that it's something that people don't want or that people are being shamed for.
Yeah, there's some resistance to
it.
I guess my perception of this question, Dr. Cooper, is that if fat is causing health problems, that's too much. Or if fat is getting in the way of your lifestyle and you're not happy with that. I think that's kind of my perception. But if I'm going to be honest with myself, a little bit of belly fat is I'm
You're not happy.
Yeah, I'm not happy about that,
right.
Dr. Cooper.
It's not something you want.
Right. Because, and then,
Yeah.
and again, it goes back to this media culture that we have of six pack abs. And if you don't have that, then you got some work to do.
Right.
So I guess what I'd love to start out, Dr. Cooper, by asking you, what is the healthiest way for us to discuss this issue?
Well, I like what you were saying, both of you, but I think that on one hand, we're talking about social constructs. We're not talking about actual too much body fat from an actual health standpoint. We're talking about too much from a social acceptance standpoint. So
I
it's
think
like
it's two separate things.
two so totally separate things. So I think it's great that people are not buying into the social construct as much as they used to. But you're right. It's still very heavy pressure in our society.
Literally.
Right. But I think like what Mark was saying, it's the mobility. If your body mass or body weight, that it is largely body fat. So like you're having to carry that around. And there are, times where that crosses a threshold where it really can be a problem for mobility. And that is really hard for people to deal with. So, that it's just difficult for them if it starts to hit some kind of level that's affecting mobility. And in terms of health, I'm not so much a believer that our body fat causes bad health or anything, except in certain situations where it's always going to be related to the metabolic problem that caused the body fat. That's the health problem, not the body fat itself normally. But in certain situations, if there's a metabolic problem that causes accumulation of fat in like your organs and impairs the organ function, yes, that is definitely a situation where the fat is causing some dysfunction. And by the way, that can happen in people of normal weight too, where they get fat accumulation in their organs. And so it's not the type of fat necessarily that weighs a lot or is very visible from like the subcutaneous fat is. But so how do we think about it? I think just keeping in mind there's like two separate things going on here. There's society's pressures and society's views and the stigma around it. And that's completely separate and apart from any kind of medical conversation. So I think we just have to always have that in mind.
Yeah. How does the average doctor, Dr. Cooper, assess someone's body weight, BMI? I applied for insurance a while back, and it's amazing how strict the BMI standards are. Who comes up with those, and is that a good gauge of this whole thing?
Oh, geez. The BMI.
Can of worms.
Well, most doctors do only use BMI. Most people use BMI as like the standard of if you're they have the terminology overweight, obesity. There's a lot of terminology around BMI. But BMI, it's an equation, height, weight, ratios. And I think it was like from the 1800s or something, like some way back when, and it was not even a medical formula at all. And it was mainly used by, I think, insurance industry and things like that. But the medical community just adopted it, and it's just been adopted widespread and used as a gauge of whether somebody is healthy or not. And there isn't anything more flawed than that. It is so not helpful. So it would be the kind of thing, if you think of like a football player, quarterback with like not much body fat at all, very lean. And then you take a person who would be, say, 5'3" person that has a lot of excess body fat that's the same weight, or not the same weight as that person, but their height weight ratio is the same. So they end up at the same BMI. So, and those two people are not the same. So it's
not
like,
at all.
Yeah. And so it's very flawed. The other thing that's flawed about it is it doesn't take into consideration gender or age beyond pediatric level, adult levels. Like as you age, it doesn't change the scale that we use. Male, female doesn't change it. And we know men, their body weight is made up a lot more muscle mass because of their testosterone than women. And so using the same pounds per square inch ratios makes no sense. So anyway, that the BMI is quite flawed. So I think if we have to use it, unfortunately, in medical care, we're kind of forced into it because we cannot get prescription medication authorized without actually diagnosing people based on this outdated BMI. It's just like an insurance requirement. So we go along with it, but I think most people know that it's quite flawed.
What are the evolutionary reasons and causes for fat, and what are the pluses and minuses? I know one time you told me that the brain needs fat to function, which I was like, oh, that's why I'm so smart. But what's the deal there? How does that go?
Well, yeah, and it is interesting. When we were talking about the brain, we're talking about the fact that the nervous system is made of a lot of fat, actually, and the brain and nervous system. So there's so much of a role of body fat in our body, and some of it is really positive. It releases some very important hormones, such as we've talked about them before, adiponectin, which is a super beneficial hormone, helps reduce the risk of heart attack, strokes, and diabetes. And another hormone called leptin, which is that beneficial hormone for our metabolism that reassures our brain and the rest of our body that we are not starving, that we have enough mass or body fat.
And so, are those both created by fat?
Yes, they're created by fat. They're called, yes. And so they're derived from fat. They're hormones. They're both hormones. And then there are other things that our body produces too, our body fat produces as well. Some of them are they promote inflammation, and so those can be a little bit more harmful, and then some of them can reduce inflammation. So our body fat plays this big important role. It also is used as a storage for energy. We need it because in case we need to tap into that for energy at a later time. It's really our only area of storage of energy other than very short-term carbohydrate storage, so that we have in our liver and then in our working muscles. So the body fat serves as the primary energy depot for when we need to tap into that. The other thing that they're realizing that our body fat does is it protects our organs from exposure to toxins, such as chemicals in the environment that can be really harmful. Our body fat can store those. Now, by storing it in the body fat, it does keep it away from our organs so that it becomes less toxic to us, but it also promotes more body fat to help store more. So the more you're exposed to these toxins, that also triggers more body fat accumulation. So that's a little bit alarming. And then for people losing weight, sometimes those toxins are released back into the bloodstream, which can cause inflammation and other issues. So it's a dynamic organ, the fat. It's actually one of the largest, it is the largest, basically, endocrine tissue in the body. So if you think of it as an endocrine mass, it produces hormones and messengers that go out throughout the body to inform about your nutritional status.
So, Dr. Cooper, we talk about subcutaneous fat. That's like the fat on your belly. We talked about having fat around the organs, but you've told us before that having too much fat around your internal organs is a bad thing and can lead to disease. How do we know where the fat is and then what we need to do about it?
Yeah. There's different ways to assess that. One of the ways is just people often would describe waist circumference measurements, which are like your upper abdomen and looking and seeing if that area is a larger circumference than your lower abdomen, because that's an area where our liver is, and the liver can store fat. And so the liver can get enlarged and cause fat accumulation in that area. So we used to say measure the waist circumference. The problem with that these days is because of the increasing rates of obesity, so many people will have, a waist circumference that would suggest they may have organ fat when they may not, when it may be just that they've got a lot of subcutaneous fat in that area. So I think waist circumference is not as useful as we used to think it was. There are other tests that test for visceral fat that are done through body composition analysis with something called DEXA scanning, which is kind of the same machine we use for bone density scanning. And then also MRI is being used to detect it, and ultrasound is being used to detect it. So it's not an easy thing to assess. But if there's a suspicion, a lot of times clinically, doctors will order ultrasounds of maybe the liver. And there's also other scans called fibroscans that can detect fatty liver and scarring from visceral fat in the organs. And so there's all kinds of ways to scan for that. But I think when we're talking about how do we even know how much body fat we have, then aside from the BMI and the scale weight, you would be measuring something called body composition. Now, that body composition alone may not be able to tell where the fat is. It depends on the method that you're using. It may just say you have X percent of your body is made of fat and the rest of it is made of lean mass. And so then you have those two numbers to work with to really understand what you're made of.
Is there a generally accepted way of knowing what that number should be in terms of fat versus lean?
You know, that is very controversial, as you can imagine, because once again, the scales that are set forth as the desirable levels that people should be at are not attainable. This is a big problem because if you read even in textbooks, if you read like exercise physiology textbooks, nutrition textbooks, medical textbooks, there are tables that say the optimal body fat percent ranges for different groups. And then if you go to the CDC website that shows what the actual body fat levels are in our population, no one is in any of those ranges. No one. I mean, you'd be like a real outlier. So that is one of the big concerns, is that there's kind of false representation of what is supposedly optimal. It's just not true. And so you have people sometimes running body composition analysis commercially, and they'll give people a report and it says, this is where you should be and this is where you are. So you need to lose X amount of weight. And those are often just so erroneous and misleading. And so you have to really take a much more scientific approach to it when you're trying to analyze. And one of the concerns is if you think of this is a measurement that's in a percentage that you get. So say someone tells you that your body fat percentage is 30% and your lean mass percent is 70%. That still doesn't tell you very much, because does that mean you have a low amount of lean mass and that's why the body fat is taking up a bigger percent, but you may have just a normal amount of body fat, not a high amount? So that's the thing. So in our clinic, not to keep saying this is how we do it, but this has kind of forced us to figure it out. The problems in this area have forced practitioners who are well-meaning to not mislead patients and give false information, and to, if they're doing an analysis, get some valuable data that you can think has some meaning. And so what we always do is try to find first, how much lean mass should you have? And so we're doing the body fat test mostly to figure out the lean mass, not so much the body fat, but do we have adequate lean mass with regard to, in relationship to your frame size, your gender, your height, all of that. There should be a minimum amount of combination of bone, tendon, ligament, muscle mass that makes up your lean mass. And if that's deficient, it's a red flag that you might have, say, bone density issues or just muscle loss. It's called sarcopenia. So we look at that first, and then that helps us really determine, where we are. And then we're looking more at absolute numbers, not so much as just percent this, percent that.
That makes sense. So you're doing things to help burn body fat. What gets burned first, and where does it go? What happens?
Well, body fat, it's very variable. If you're in a body fat loss mode where it's burning, our hope is it's going to burn from the internal organ area first, the visceral fat. That's where we really care about it, where it could be interfering with organ function. And so that's our hope. And then when we have kind of a successful metabolic approach, usually that is what happens. But some people don't even have visceral fat very much. I mean, that's one thing that's misleading too. You could be a very high body weight person and have very little fat in the visceral area and have all your body fat being more subcutaneous. So I guess it depends too on where your fat was to begin with, of what you'll burn off first, and then how you're trying to burn this fat off. If you're on a deprivation diet, unfortunately, what they've noticed is it's not normally the visceral fat that will burn off. And in fact, that terminology that we've used before, it's called weight cycling, where people go on a diet and then
up and down, up and down.
Yeah, up and down. There's an association with an markedly increased risk of accumulating more and more visceral fat doing that. So again, it depends on how you're losing this weight. And a lot of the medications that are out now are being used to target the visceral fat better. And they're still investigating some upcoming medications that can be useful in fatty liver disease and things like that to help reduce the fat burden in the liver. But I think improving metabolic function is the key. Improving the metabolic function and then allowing the body to feel that it doesn't have to store all that excess fat because there's a better sense of security in the system. And that means fueling regularly, medications where needed, and then monitoring.
So if you got liposuction, where's that fat coming from? And then I know you told me that fat can come back, even though they say, oh, it's permanently taken away through the suction needle or whatever. But like, what really happens if you do that? What is that all about? What is it really the miracle that they promise you on TV?
No, it's not. In fact, I get real nervous.
Me too.
I get very nervous about people pursuing liposuction because there can be times where it actually triggers more fat accumulation following that procedure. And those would be especially times where you go into that procedure with your body already thinking that you're in a starvation mode, and then fat is removed. And remember, we said fat releases those beneficial hormones that reassure your body that you're not starving. So by taking that fat out, you're actually removing some of your body's leptin, which is that important hormone. And then your brain senses that somehow your weight dropped even lower than it thought, and it already was alarmed. So, of course, the brain does its thing and can redirect the way the metabolism is operating and enable you to store more and more body fat.
Wow, that is really interesting because these surgeons are saying, oh, we can sculpt your body, and they're taking it out of the body, not realizing that that's part of a very complex system that your brain relies on to figure out how much fat you have.
Yes, wow. It's true.
Linda Evangelista, famous supermodel, just had a huge court case that she had a liposuction and I think a couple other things and cool sculpting, and it triggered all kinds of things and put fat back on her body in the weirdest places and basically ruined her face. It ruined her body, and she couldn't work for a while, and then had to go through a bunch of other surgeries to fix what the cool sculpting did to her.
Oh man, wow. That's wild.
And the body fat is vascular tissue. It's not without risk, the liposuction procedures. But our patients, some of them who, where their weight has decreased quite a bit and now they have a lot of loose skin, that's okay to remove the loose skin that's chafing and rubbing and all of that. But we always advise no liposuction because of that risk.
I think it would be good to talk, Dr. Cooper, about the GLP-1 drugs like Mounjaro and Ozempic that cause the body to burn more fat, or at least the fat goes away. I know this is a very complicated question, but how do those drugs result in less body fat?
Well, if we could keep it really simple, again, the whole concept of why the body will store an abnormal, say, amount of fat is really due to that famine signaling issue and a lack of security signaling. And they have shown people with high body weight have blunted perception in the brain of the actual food supply and energy availability, that it's not how they think consciously, it's a chemical issue. And so this has been well documented, and they don't always have a normal response to food. When we eat food, certain hormones are supposed to change, and those changes are not occurring the same way. And so when you think about it and keeping it simple, excess body fat would just be because of an imbalance of famine signals versus security signals. You know, the ones that say we're starving versus the ones that say we're secure. There's an imbalance there that's favoring fat accumulation versus balancing out and burning that excess fat off. So what the medications are doing is they're adding to the balance of the security signals. They're boosting the security signals. So by boosting that security signal, it's reassuring the whole body that no, there is enough food. We're not in a food shortage. It's all okay. So green light metabolically. So it's just changing that imbalance and enhancing the positive side, which really also does tend to diminish the famine signals as well.
I always say that my brain is saying that it sings that Let It Go song, you know, from Frozen. And it's like my brain is saying, okay, you got enough. Let it go. Let it go. And it will let some of the fat go. It's still not hearing it loud enough, but it can hear it a little bit and it will let some of the fat go. Whereas before, it didn't hear any of it. And it was like, oh, got to protect it. Don't let it go. Protect.
And those medications are mimicking our natural hormones. And people that are not weight challenged have those hormones releasing and functioning normally. And so then other people that are more weight challenged, do you benefit from taking an hormone mimicker?
It's a
because
booster.
Theirs are not working correctly. Right.
Andrea, you mentioned this earlier, and I'd love to ask your opinion about it, Dr. Cooper. I think some people who are really into fitness wear this percentage of body fat as sort of a badge of honor. Like, I'm down to 5% or 3%. That doesn't sound healthy.
No.
The goal should never be to like drive your body fat percent down as low as possible. And it could be a disease if you start to see people that are, driving it down that far. But and it also depends with athletes, like some seriously competitive athletes. Also, if you're doing a long endurance event and your body fat is too low at the start line, you're probably not going to finish that event very well. And so there's a certain amount of body fat that you absolutely need to have in reserve. And so I think that is very misleading when people are focusing so much on this really low body fat. And so much of the time, people are surprised when we tell them, wow, everything's like in the optimal range. It's in the fit optimal range. And they thought that they should be losing all kinds of body fat. And we're like, no, you're actually in a really balanced range where you are. But it's interesting, too, that from a BMI standpoint, we talk about BMI being flawed, but they have done studies that show that as we get older, like 65 and over, all-cause mortality drops with higher BMIs. So if you're under a BMI of 23, which is still in the normal range, normal, quote, normal is considered 18 to 25, which is, we always don't think of 18 as normal, but even at 23, under 23 BMI, mortality rates increase in 65 and over. And they only increase again once you get all the way up into the middle of class 1 obesity range. So even in like a BMI of 30, which is classified as obesity, the mortality rate is lower than if you have a BMI of 22 in 65 and over. So there are advantages to having some extra body weight and body fat.
Wow. So as we get older, if we're too skinny, you're saying that skinnier people like that die sooner?
Yes. Mm-hmm. Yes, that's been shown that it's basically all-cause mortality when they equalize for everything, especially the people who have been smokers in that category, but even non-smokers in that category versus non-smokers in a higher BMI range, there's an increase in their all-cause mortality. There's also evidence that women who carry more body fat around their hips and lower abdomen, than if you don't carry body fat in that area, those women are healthier, the ones who do carry body fat in the hips and lower abdomen. Extra body fat there is beneficial.
That's interesting.
So
maybe because
what are those called?
Maybe because they break less when they fall.
It's more than that.
They bounce a little bit.
It's more than that because it really is across a broad area of health parameters.
Oh, that's good to know.
Yeah.
Andrea, when you were quote unquote being treated by doctors over the years for weight, did they ever give you a target? Did they ever give you any idea of what they thought your weight should be or your fat percentages should be?
Well, they would always show me on the BMI chart where I should be, which was, at most times like half of what I weighed, which I was like, oh God. So it always seemed kind of unattainable, and that they would just sort of walk away and be like, here's a diet or here's a thing that I would be like, oh, just a couple of lettuce leaves a day. Here I go. Piece of boiled chicken and a lettuce leaf.
Oh.
Yum. A boiled egg. Yay. How exciting. But the weird thing is, it's very strange. Believe me, still perception is a lot of reality. And, I still look like a lot of people's before picture. So it's not necessarily all there yet. But in a lot of ways, when I was at my largest, I was my most invisible person. Because when you're really big, you're invisible to a lot of people. They walk right by you, they don't talk to you or whatever. And now, as a smaller person, you're much more visible. So it's that part is very interesting to me.
Mm-hmm.
But I feel like I didn't do this to be visible. I did it for health, and we always talk about health. And yet culture is all about how you look. So it's always for me, it's sort of the process that I've gone through is always at sort of a clash because everybody's always like, oh, you look so good. You look so good. And I'm like, I didn't do it for that. I did it to get healthy. And I always try and stress that with people because everybody always thinks you did it to like look better in your pants. And that's not why I did it. And I think that that's a really important thing to talk about.
Yeah. I think that would be a good place to wrap up, Andrea. Dr. Cooper, I'd like to give you the last word on that. If somebody's still struggling with the idea of how much fat is too much fat, what could you tell them that might ease their mind a little bit?
Well, I think getting a good health checkup too. And if there's no evidence that you have visceral fat, fatty liver issues, your organ function's good, your cholesterol panel's great, you don't have prediabetes, you don't have insulin resistance, you don't have hypertension, well, then it's really, it's not that your excess body fat isn't a metabolic result. It most likely is due to some kind of imbalance metabolically, but it becomes not as critical to address it because it's not harming you. It's not harming you. So, but I'm all in support of people that do want to address it in spite of the fact that they are healthy, because people should feel like they want to feel. They should correct imbalances if they want to correct these metabolic imbalances. But I'm also supportive of people that are totally comfortable with their body and are, there's no pending health issue that they need to address. And if they're comfortable and they're not dealing with mobility issues, that's great too.
So, How much fat is too much fat? Well, fat is one metric of many, many things we can measure when it comes to our health. I feel like this has been a good discussion today. Thanks to both of you, Dr. Emily Cooper, Andrea Taylor, for another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.
I'm Mark Wright. Thanks for listening to Fat Science with Dr. Emily Cooper, a Work P2P production. New episodes drop every Monday. If you've enjoyed the conversation, subscribe, rate, and review this podcast. This production is for informational purposes only and is not intended to replace professional medical advice. Join us next week for another episode dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better.